participants from 4 different countries, Mozambique, Nigeria, Tanzania, and South Africa. So welcome. G-ECHO is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. So thank you to our colleagues in the US. G-ECHO runs every Monday at 4:30, which you guys have well worked out. Well done. And please feel free to interact at any stage during the talk. I'm happy to chat and discuss through things, whatever you find controversial or interesting. I'm happy to chat about it. So please shout out, feel free. Okay. I'm not very good at checking the chat function. So better if you just raise a hand and we chat about it. Cool. So I'm going to figure out how to share my screen.
Okay, it's all there.
Great. So tonight I wanted to chat to you guys about anal fistulae. Something we haven't done very commonly over the pandemic now. We've only really been dealing with cancers, but it was quite nice today. Certainly we did a fistula list, which was kind of fun and exciting. Some of our registrars wouldn't have seen that for the past 2 or 3 years. So it seems like we're getting back to normal, which is very nice. So today I want to chat to you about the anatomy, etiology. We'll look at classifying fistulae, try and figure out that impossible task of how do you get fistula to heal. I would like to emphasize that fistulotomy is by far the best treatment for anal fistulae. There are other less effective options out there. And then since this is part of the Gastro Foundation talks, we better do a special mention for Crohn's fistulae, and then we'll bring it all together in the end. So anal anatomy, very important. Obviously, vitally important that certainly the surgeon understand it, and because it's absolutely vitally critical to the patient. There's a lot, both anatomically, physiologically, and functionally, that make the anal sphincter work really well, and we're all that much socially acceptable when we have a working anal sphincter. Most textbooks don't cover a whole lot very well, certainly not the detail that a surgeon needs to know. And there is this article that I found really relevant for any of you surgeons out there. If you want to go and look in detail and you plan on operating on the anus at any time, in the Annals of Coloproctology in 2018, there's this very detailed article on the essential anatomy of the anorectum for colorectal surgeons. And that's just a really useful thing to go and look through and read through, with great pictures, surgical pictures, that deals with everything greatly in detail, and I highly recommend that you go and look at it in detail. In terms of when we're discussing anal anatomy with our colleagues, it's really just useful to remember the basics of describing anything you see as the clock face. So anytime someone picks up the phone and wants to refer something to me, or you want to refer to some of your colleagues, certainly our default is looking at things according to the clock face. If there's a lesion on the anal canal, if there's a fissure, if there's an external opening or something, describe it in relation to the anal opening and exactly where on the clock face it fits. Okay, so anteriorly is 12 o'clock, posteriorly is 6 o'clock, and then describe it like that to whoever you're speaking to. So in terms of perianal sepsis and etiology, I mean, there is a range, okay, starting out from acute abscess, and you've really got to think of anal fistulae as a chronic form of perianal sepsis. So somewhere along the line, an abscess started, some infection started, it didn't heal first time around, and it became a chronic anal fistula. Okay, so something's gone wrong. The vast majority of anal fistulae start out as in cryptoglandular theory, all right? And you've got to be able to explain that neatly. Very simply, infection starts in the intersphincteric space, okay? So between internal and external sphincter, within those anal glands, something blocks them. The internal opening, remember, is always at the dentate line, okay? And this infection starts, and then it tries to get out in various ways, and that's when the trouble starts. But do remember that cryptoglandular theory is not the only way that infection can happen within the anal canal, and now we can end up with perianal sepsis. So certainly inflammatory bowel disease, particularly Crohn's disease. Okay. Certainly on the tip of Africa and South Africa, we see a healthy amount of TB, unfortunately, still. So infectious diseases are still a problem for us, and we do see TB in the perianal region. HIV contributes. You can see some really strange anal ulcerations in various ways. Trauma, surgery gone wrong can definitely end up with fistulae, as well as malignancy. And in terms of all of those things mentioned, it's really quite key that anytime you're taking these patients to examine them under anesthetic, just take the opportunity to biopsy. So if you've got the opportunity to get a little bit of tissue, just to make sure you know what's going on, take that opportunity and biopsy it. The only time I would say that you don't biopsy, okay, is in tissue that doesn't heal well, and that's previously irradiated tissue. So if you know the patient has a history of radiation for the prostate, invariably you damage at least part of the anal canal and rectum, then don't go and biopsy that obviously irradiated tissue, because that doesn't heal very well and you can get large ulcers then. So in terms of classifying patients, one of the commonest ways we classify patients with perianal sepsis is we look at something, and of course it had to be named after someone, but is known as Parkes classification. So one of my fellows on the call, Zubair Salih, are you around? Do you want to tell people about Parkes classification, what you remember of it?
So
sorry to put you on the spot, yeah.
So the Parkes classification actually dates back to 1976, and it was all based on the cryptoglandular theory by Parkes himself. So it was not based on any clinical radiological findings at the time. And he postulated that it didn't actually include superficial fistulae, but people now do add them of late. So as you got in your drawing at the bottom there, the one that does not traverse the sphincters at all would be the superficial fistula. And then the one on the opposite right-hand side would be your intersphincteric one. And then going back to the other side where it traverses the external and internal sphincter would be the transsphincteric. The one on the right-hand side of the screen that goes above the anorectal ring and then dips back down is your suprasphincteric fistula, and the one on the far end on the left-hand side of the screen is your extrasphincteric fistula.
Awesome, thank you. And the reason we bother, or Parkes bothered to go and try and classify these fistulae in various ways is just to try and quantify the complexity and how difficult it was going to be to manage these in the future. So it was a way to try and classify them and work out, well, what can we do about these things? Of course, there are other ways to classify patients. And one of the simple ways we do in theatre, which is we used quite a lot by surgeons, is looking at very simply at Goodsall's rule. And this looks at a horizontal line, imaginary line drawn through the anal canal. Anything below that line, okay, is going to be a complex fistula. It horseshoes round and it opens at 6 o'clock. So I told you about the clock face and how we describe things from the start. So Goodsall's rule, anything opening below the line, so the external opening on the skin is running between 3 and 9 o'clock, that's going to horseshoe around and open at an internal opening at 6 o'clock. Now, no rule is perfect, but it's amazing how useful that is in theatre when you're looking for internal fistulous openings. Okay, and then you can take it very simply, and you could also classify them into simple and complex. And again, it tries to stratify patient fistulae into how we manage them. So simple fistulae involve less than a third of the anal sphincter. So according to Park's classification, they're intersphincteric or low transsphincteric. Okay, and anything else is complex. Okay, so beware the anterior tract in a female. Remember, female have shorter anal sphincters than males. Any recurrent fistulae, any multiple tracts, if you've got IBD associated with these fistulae, you've got to be very careful how you manage them. And it's not the type of fistula you're just going to lay open. Okay, so simple and complex, easy classification to remember, actually very clinically useful. Of course, the holy grail is, how do you cure a fistula and have no risk of incontinence at all? So how do you not risk continence? And actually what you've got to bear in mind is any division of any muscle carries some risk. Okay, a third is not really a magical number. And what you have to balance up, and more importantly, what your patient has to weigh up and understand, is how much continence they're willing to risk in the management of their anal sepsis and their anal fistulae. So laying open a fistulae has been described since the late Middle Ages, been going on for ages, all right? And it's taken quite a long time actually for new treatments to develop. And they've started to become more prevalent as patients, and rather appropriately, have become more concerned about their continence, okay, as well as cure. So sure, they're very happy to have their sepsis drained like you would any abscess, cut it open. So they're very happy to have their fistulae cured, but surprisingly, they don't want to be incontinent. Of course, what incontinence means is highly variable. And there's a spectrum between flatus incontinence all the way to solid stool incontinence. So these important concepts that you need to speak to your patients about. Although there is no doubt that the best treatment of anal sepsis of any kind is to cut it open. So 100%, the best treatment for anal fistulae of any kind is a fistulotomy. All right. There is no other treatment on the market, no matter how many congresses anybody will pay for you to go to. There is no other treatment that is as good as cutting it open. All right. So very simply, in theatre, what we do for an anal fistula is stick a probe down the tract. Not always easy to find the tract, but in a simple linear tract, you would lay it open. You would lay it open entirely, strip out the fistula tract, and that heals remarkably well. And as long as you haven't cut too many of the sphincter fibers, is a very effective treatment for anal fistula. Okay. So the major problem, and why it all becomes very debatable, is we can't offer everyone the best treatment. Okay, so I'm a bit hamstrung because there's some people who unfortunately got too many of their sphincter fibers involved in that fistula tract, and I actually can't offer them all the best. Okay, and it's not quite actually just as simple as how much of the anal sphincter is involved. Okay, there's some other considerations as well. So the patients you've got to think about is, does this patient actually have loose or frequent stools, i.e., are they someone with UC? Are they at risk of running into trouble in the future? So do they need every last anal sphincter fiber in order to keep them continent? And so that has to be a consideration when you're discussing with a patient how much of the sphincter you're prepared to divide or not. Again, remember the shorter anterior canal in females, okay? And remember that if someone's going to have 10 children, okay, and they're going to push them all out vaginally, there's a good chance there's going to be some damage anteriorly to the anal sphincter. So that all must be considered when you're working out how much of a sphincter you're prepared to risk or how much the patient's prepared to risk. So when I can't offer someone the best treatment, what can I offer? Okay, there are lots of varying options, but by far, okay, the safest, best, sort of the time on a tested thing that works remarkably well, okay, is a Seton. Okay, so a Seton is a piece of vascular tape. And the reason we choose vascular tape is designed to hold vessels. So designed not to damage anything. And literally, you cannulate the tract, find out where it is, figure, oh, I'm a bit concerned. You've drained the sepsis. You think, oh, how much of this muscle is involved? And then usually I thread a piece of nylon along our fistula probes. They've got a nice groove in them. It's easy enough to do. Tie that to the vascular tape, railroad it through, and then just secure it with some silk ties to keep it in place. All that does is it keeps the tract open. So all it does is it drains sepsis. Okay. Works remarkably well in helping relieve pain if you're in the correct tract. And there's some patients who would say, yo, I've had 10 EUAs before, fairly pain-free. Sure, there's a little bit of pus that comes out every now and again, but actually just leave me alone. I'd like to go back to work, not lose out on work days, and I'm happy to live like this. And there certainly are a group of patients who can, and that is perfectly reasonable. There's certainly no thing required that you need to change Setons or anything like that. They can stay in for as long as they work, as long as they are not troubling the patient and they're doing their job. So what happens when patients, unfortunately, go the opposite way and say, look, this is terribly miserable. I really hate this Seton. What are the other options? And this is really sort of the A to B in what we do every single time, we assess a fistula and take a patient to theatre. The commonest presentation is in that top picture where there's like a little bead of pus, what looks like an external opening. And if you look at one at the top, happened to be, if you followed Goodsall's rule, that one would horseshoe round and you'd end up at 6 o'clock with an internal opening. So these tracts, as they run, you find the tract, you sort of hazard a guess of how much of the muscle involved. One of the key things, your anaesthetist can't give a whole bunch of muscle relaxant. Okay. Otherwise, you're going to cut through muscle fibers no end and not even know you're doing it. So it's quite keen that they can, they can't give long-acting muscle relaxant when you're doing these type of operations. So we find the tract, if we worried in any way, we just put a little piece of vascular tape. They happen to come in red, blue, and yellow primary colors for some reason. So sometimes I discuss with the patient what color they want. Some are particular when they've had lots of Setons. And you literally use that for drainage. Then you go and have a think about it. Think, okay, how do I classify this? Sometimes things settle down quite nicely with once the abscess is drained. And you can try and figure out what to do about this. And when things are still a bit tough, then I throw in an MRI. Okay. It is not something we need for every fistula tract. Okay. By far the majority we can assess clinically. Okay. But there is a group of patients where we are struggling, where MRI is helpful, particularly for undrained sepsis, for particularly deep tracts. And so there is a group of patients where I do send for MRI, and then we'll look at the MRI and basically gives us a roadmap of where to go and drain the sepsis if there's any undrained sepsis. Okay, so what are various other options? Okay, and the simple rule in any surgery is when there are lots of options, lots of ways to treat something, none of them are any good. Okay, so I can't stress enough that fistulotomy, okay, basically cutting open the tract, draining the sepsin is the best treatment. I can't offer everyone the best treatment. So what are the other options? Okay, so there are various ways of blocking, plugging the tract in some ways. So various fistula plugs, various glues, stem cells. Today we tried a procedure of taking the patient's own blood, extracting that, putting that in the fistula, putting that in the fistula tract. We're all desperate to find the holy grail of what works. Probably one of the best design studies, purely because I thought they were entirely honest about their results. But I think what sums up just about every single fistula treatment or article I've read on fistulae is Willem Beerman and colleagues from the AMC looked at a randomized control of fistula plugs versus mucosal advancement flaps. And I loved his quote at the end. He basically said the result for both interventions was disappointing. So he took what, if you look at the literature at that stage, would be the gold standard after fistulotomy, which would be mucosal advancement flap. And if you read much of that literature, most of it will say it's got an 80% success rate. Well, when you randomized to mucosal advancement flap and anal fistula plug, neither came close to achieving 80%, which is particularly disappointing. Something I have used in the past is a LIFT, okay, which is a nice acronym, works well for us. Tricky, depending, you've got to pick your fistulae well. But looking at ligation of the intersphincteric fistula tract. So there are various ways that you can do it, but basically you go and find the fistula tract in that intersphincteric space where you believe that, if it's cryptograndia theory, where you believe that trouble to have started, and you go and divide that tract in the intersphincteric space. So again, I generally say to patients, you got a 50-50 of that working. Although on occasion I have had patients who, what has happened is they've then converted their tract to an intersphincteric tract instead. And that I can remember one patient quite particularly was quite happy with that outcome. Although his fistula wasn't entirely healed, his opening was right within the anal canal, and he could manage that just quite a lot better. Cutting setons, there certainly is literature out there, which is slowly tightening the setons, basically slowly cutting through the sphincter fibers and then healing via fibrosis after that. It's not something that I'm particularly keen on trying. It's quite painful for patients. So, you know, you need quite a dedicated patient, but there are some enthusiasts who are quite keen on cutting setons. There are various ways of trying to ablate the tract with radio frequency ablation, with laser ablation. You could even take a highly expensive little video camera and do a video assisted anal fistula treatment. So put a very expensive tiny scope down a fistula tract and follow it to try and figure out where the tract is in order to lay it open. You can also even take an over the scope clip that we sometimes use for GI bleeding, or so you can even take that to try and close, and there is a proctology clip for that to try and close the internal opening. So there are various options. Each gets more and more expensive. Fistula disease is common. So if someone does find the answer, they are going to make a lot of money. When all else fails, you can still do a stoma. Of all the things mentioned in the literature, when you go and read, advancement flaps seem to have the highest reported rates of success. Okay. Practically, I've spent a lot of time berating myself going, how on earth did anyone get 80%? And I actually, over the years, when we've had a couple of proctology congresses, tried to get international speakers to come and do things on talks on like how I do advancement flaps, to try and explain to us how we can get this 80% success rate. I've never been able to find a speaker to do that because they all look at me like I'm crazy and go, no one gets 80%. So I've given up trying to find that. These days, more likely 50% success rate. So basically, at least half of your next best option, these patients fail. The major problems with doing advancement flap is you really need to include part of the circular muscle. So you're going to disrupt the anal rectal junction. And if this all falls apart, your patient will be worse off. Okay. And that's quite key with any fistula treatment, is whatever you do to a patient, you don't want them to be worse off when they started. So that's quite a key conversation to have to patients. So look, 50-50 chance. And if this flap doesn't work out for you, then you may well be worse off than when you started. So another key take-home message if you're going to operate on anal fistula is don't make things worse, whatever you decide to do. So in terms of the surgical principles for anal fistulae, the key operation is fistulotomy, fistulotomy, fistulotomy. Okay. You can do a fistulectomy if you want. I mean, same outcome, same healing rates, both are perfectly acceptable. So if you want to go and core out the tract at the same time, ectomy, otomy, same outcomes. Simply, if a fistulotomy is not possible, then a Seton is your get out of jail free card. Okay. When you're managing these very complex ones, just deal with the extension of the cavities first. Okay. An MRI is sometimes useful. Okay. It's not your first line investigation, but it can be useful. And then if you can't do fistulotomy and your patient doesn't want to live with a Seton, then whatever sphincter saving procedure is your preference. Okay. But your key message is don't do any harm. And really sit down and chat to your patients, because expectation setting for patients is vital. Once you get in the realm of complex fistulae, that patient's going to see you a lot, okay? And their heart's going to sink each time they come back with some sort of abscess and Setons, so is yours. So you really have to set expectations that once this develops into a complex fistulae, if there are multiple external openings, that this is a process, okay? And they've got to be with you for the whole long process. Initially, I try and, minimize the external openings, bring them down to one tract. Once you're left down with one tract, with one Seton in, then you plan for that one tract, okay? But you need to manage those expectations. Okay, then we move on to the thing that we all hate dealing with. First of all, are there any questions on cryptograndular fistulae? Anybody want to ask anything? Cool, okay. Then I'll move on to perianal Crohn's. So perianal Crohn's is complex, okay. We know our key take-home message for cryptoglandular fistulae is we'd ideally like to cut them open. All right, so I'd like to do to all of those fistulae. Some of them we can't because of their proximity to the sphincter and what they would mean for continence. But Crohn's has a slightly different take. Okay. Our key take-home message are to drain sepsis, but you're going to do that carefully. Bearing in mind, in general, Crohn's patients don't heal very well. Okay. You might need more than one Seton, okay, to drain complex sepsis. And the mainstay of treatment for perianal Crohn's is start a biologic, okay. It's a medical disease, and these patients need medical treatment. All right, I'm quite happy to admit that the only thing I can help these patients with is complications, okay, and draining sepsis, okay. As a surgeon, I cannot cure perianal Crohn's disease. So of those who have Crohn's disease, unfortunately, about a fifth will end up with some form of perianal fistulous disease by 10 years, and that increases slightly by 20 years. Okay. For some of them, and those are the interesting ones to consider, it might be their only disease, particularly on presentation. So a surgeon has to be well aware of that. If anything looks slightly unusual. Again, this is where your biopsies and examination under anesthetic always come in useful. Just be aware that even when it's the only disease and nothing going on, it may still be Crohn's disease. So it is worthwhile chatting to patients about their bowel habits, okay, because you might find out some interesting things in their history, okay. Crohn's fistulae are very demoralizing, okay. In the very best hands, maybe a 50% cure. And this is a real healthy combination of medical and surgical management in order to try and achieve this. Of course, it's highly debatable at what cure is, okay. So we all know, reading the literature and looking at studies, that some people could call cure if you press on the outside of the fistulae and no bead of pus comes out of that, that's cure. All right. Sometimes patients would disagree with that, though. So in terms of sort of conventional therapy for patients with perianal fistulous disease, particularly in Crohn's disease, now we're talking, there's no role for aminosalicylates and steroids in perianal fistulous Crohn's disease, okay? All you're going to do is precipitate more sepsis, okay? So you throw steroids at these patients, they're just going to get perianal abscesses for you to drain regularly, okay? Some of the studies out there have tried various things. I really do like the people who tried metronidazole and managed to publish their initials of they're looking at their initial randomized control data of 7 patients. That didn't work at all. All right. So in case any of you are keen to try metronidazole, that doesn't work. In terms of biologics, okay, find a MAB out there, and it will be tried, and it will be tried in the future, because you're all desperate to cure perianal Crohn's disease, and they should be tried. Okay. So depending on what you look at, some of the older data in infliximab claimed a 55% fistula closure rate, but the same as in all interventions with fistulae, when they're around long enough, that just drops to 36%. Okay, so all in all, these patients do need a biologic. It certainly is an indication for a biologic. What that is debatable. There's a nice overview in Gut if you're looking to read a bit more on, I don't know if 2018 could be called Modern Management of Perianal Crohn's anymore, but in 2018 it was titled Modern Management of Perianal Crohn's, which gives you a nice overview, because most Crohn's literature doesn't look particularly at perianal fistulae, so it's all a subgroup analysis of a bigger group. But this gives a nice summary overview. The key thing and the top of this algorithm is these patients need medical management. They need medical management, medical management, medical management. You're going to take them to theatre to drain any sepsis. They may require a Seton, okay? And then you're going to check them up again. You're going to look for mucosal healing. Either that's going to work, so the biologic is going to kick in and things are going to start getting better. The difficulty when they're getting better is when to take out the Seton if they've got a Seton in, okay? And that can be quite challenging. You've got to go clinically, obviously, check that, you know, pus stops draining, they're not in any pain. Debatable whether you need an MRI to confirm whether they don't have any more abscesses. But it's not unreasonable to take a Seton out. Removing a Seton in the clinic is particularly easy. So that's not a problem. And then seeing whether this fistula remains, you know, to heal or not. The difficulties on those where the disease remains active, okay? So you can try, if you have any other armamentarium, other biologic measures, but in the end, you may need to try something, okay? And that something is just as difficult to try and figure out. You could try anything, basically, in the armamentarium in terms of plugging, glues, waft, Filac. People have even gone as far as to try local injection of anti-TNF. Okay, I'm not sure why they think that particularly would work more than systemic treatment, but that has been tried as well. So in conclusion, anatomy of the anal canal is very important to you as the surgeon as well as to the patient. Don't miss an opportunity to take biopsies at every opportunity. We have had patients with chronic sepsis who 10 years down the line, unfortunately, have developed a cancer. By the time they've got so much sepsis and fibrosis on board, it's very hard to make that decision at a wake examination. If they happen to be in theatre, just take the biopsies. Okay. The classification systems are helpful and they plan various treatment options. Fistulotomy is head and shoulders above the rest in terms of best treatment. Okay. Unfortunately, everyone can't get the best treatment. Okay. For various reasons. Okay. Mostly because they're not willing to risk the incontinence that goes with it. Some patients will tell you just rather cut. I can't live like this anymore. I don't mind if I leak a bit. And there are others that are completely terrified of even leaking a bit of flatus. So you must discuss it with them. And all other fistula treatment options are very disappointing. Okay. Crohn's fistulae are challenging. Okay. Less is more generally with them. But the bottom line is Crohn's needs to be managed by medical treatment. And surgery, we're only there to help with the septic complications. Unfortunately, we cannot cure Crohn's disease. Thanks. Are there any questions from the audience? All right. I saw Gert's hand go up there, and then non-coliseco.
Hi, Claire.
How's it, Gert?
All right, thanks. Thanks for the talk. Excellent presentation. I really like the take-home message that the only treatment really for the fistula is a cryptoglandular fistula, I have to say, is a fistulotomy. I would like to ask if and when would you consider an APR for a patient who's just so miserable with his perianal sepsis and you just cannot get on top of it? I mean, obviously having excluded all other diagnoses, would you consider that?
So it's not out of the realm of possibility, unfortunately. I can recall having done it once. Okay, so it's not something that I've rushed into. I'm also very aware these patients with these non-healing, fistulous bottoms, you've got to wonder why aren't they healing in the first place? And if I go and give them a big shark bite of a cut, what are the chances of that's going to heal? So you do have to be aware of that, but I certainly have done it for one patient. More often than not, we'd give them a defunctioning stoma first. Okay. So they can then figure out what life with the stoma is like. The vast majority of patients will settle down enough to cope just with a defunctioning stoma. But it's on your armamentarium, but low down.
Thank you.
Cool. Non-coliseco, you had a question?
Hi, can you hear me?
Yes.
Hi. Oh, great. Thank you for the talk. I wanted to ask about Setons, and do you place them, go in and replace the Seton, and how often do you do that if the fistula hasn't, healed? So what's your management of the Seton? And like when you speak to the patient, the expectation of how long they'll have it for, what do you normally tell them? Just the practicalities of Setons.
Absolutely. Yeah, look, I know that hard conversation you're talking about, okay, because these patients come to you and they view fistulae very much like an abscess, like you're going to cut it and they never want to see you again, okay, and actually you've got to start that conversation right from the beginning. because you need to manage that expectation, because you're gonna fail that expectation when it comes to fistulae. So, I mean, I can tell you, in my naivety as a young colorectal surgeon, one of my aims was to go and do a fellowship elsewhere, and one of my primary aims was to go and learn about anal fistulae and like what are the new things we could do for them and how can we make these better. And I spent 6 months elsewhere, and I came back. And by that stage, I'd helped them with a book chapter on fistulae, and we'd done a bunch of things. And unfortunately, I came back with the exact same view that if you can't lay open a fistulae, a seton is by far the best treatment. Okay, even in a first world setting, it's amazing how many people are walking around with setons. Seton is a good long-term management. Okay, so if a seton is in the appropriate tract, patients can live with them forever. They don't need to be changed. Okay, it literally functions as a drain. Okay, and I will only replace, so we have a couple of patients who live forever with setons, and they'll only pop in if they're developing pain or sepsis, or if their seton's fallen out. So we have no program in terms of exchanging setons. It's not necessary. Okay. So, you know, helpful in state, because we don't, but if you're making money doing, you know, in private practice, sorry, you only need to put in a seton once, and unless it falls out, you know, it's not going to be a lucrative business. In terms of what you're going to do in the long term with them, very much depends on that very important conversation you mentioned with a patient. So some would say, cool, I'm fine, let me get back to work, leave me alone. And then there is that group who go, this is ridiculous. How can you expect me to live with this thing hanging out my bottom? I mean, that's just insane. Okay. And they'll never accept that. And then for that group, what I say to them is, look, okay, we have to leave this in for 3 months. Okay. 3 months is my magical accepted time. Okay. Then I reassess them. Particularly if they've never had a seton in before, it's a really actually useful examination to examine someone awake with a seton in. Number one, you can feel where the internal opening is beautifully. You can palpate the tract quite nicely. So it's a useful awake exam, more so than someone who doesn't have a seton in. So I start with that. Sometimes I'm pleasantly surprised. So if patients came in septic, we, you know, just drain and put a seton in. And then once that's all settled down, sometimes you realize that tract is actually a lot lower, involves less of the muscle. You've now can have that conversation with the patient and say to them, look, you know, we're here at this point now. It now looks much easier. And actually, this is probably amenable to a fistulotomy, which is the best treatment for a fistula. And I'll go ahead and offer them that. Okay. Then there's that group who it's not amenable to. And then I'll try other things, and that depends. Okay. So I have tried fistula plugs. I say to patients, look, fistula plugs, about a 10% success rate. Okay. The only reason fistula plugs still exist with a 10% success rate is it doesn't do harm. Okay. So it doesn't change the tract in any way. I will tell them I could do a lift, which is ligation of the intersphincteric tract. That option, 50-50 success rate. It does mean some dissection in that intersphincteric space. Okay. So I'll give them 50-50 options on that. So those are the usual things I offer them. Okay. But don't undersell a seton. A seton, I think really what I want you to understand is anal fistula, seton is not failure. Okay. It's actually a very good treatment option. I used to view it as like complete and utter dismal failure. And I think the way we talk to patients actually couches how they understand setons. And it's not complete failure.
Thank you.
Cool. Sorry, I spoke a lot there. Anybody else? Mohammed, you ready for your exam? I see you there.
Hi, Claire.
How's it?
Yeah, yeah, I'm
Cool.
trying. Thanks.
Good, good. Cool, great. I can't see any other questions. If there are no more questions, then let me see if I can figure this out. Cool. So thanks very much. Thanks to ECHO, University of New Mexico, and the ECHO India team for the support. There is a feedback form available in the chat. And there are recordings available on the Gastro Foundation website. So thanks very much to the Gastro Foundation. And the next talk will be on the 9th of May is the next scheduled talk. So thanks very much, guys. Have a good evening.